But it's a very interesting place. It was the first place, it's the first country really where the slaves sort of overthrew the local masters. Basically, it had about 1/3 of all the slaves in the northern hemisphere. It was considered the Pearl of Antilles. It was an incredibly rich, rich country. And inspired by the French Revolution, the slaves basically rose up, threw off their masters. But of course, the French didn't want to buy that. And Haiti actually didn't finish paying reparations until 1947 for their independence. So it's a very sad country in many ways and many terrible things. In 1991, Jean-Bertrand Aristide, don't worry, you're wondering, what the heck is this guy talking about? Jean-Bertrand Aristide was one of the first democratically elected presidents of Haiti, and it was a very, very promising thing, and here he is sitting by the chief of staff, and the people were very, very happy and excited, and all kinds of very exciting things were happening in Haiti in 1991. But he was also really challenging what was going on. And the guy who's sitting here now, there he is on the balcony of the presidential palace in 1993. There was a coup in 91, and by 93, Cedras and his supporters had basically created a reign of terror, okay? And many of the fledgling civil society measures and healthcare and education, et cetera, were really being destroyed by this person. Shortly before 93, the world got together and imposed sanctions on Haiti, okay? And that's where I come in, because in 1993, I was doing my master's in public health in Boston, and I had done some work with a group called Physicians for Human Rights. And there was a professor at Harvard who had been requested by UNICEF to do work on the impact of sanctions in Haiti on the health of women and children. And people thought that this project should also have a human rights component. And so people at PHR, Physicians for Human Rights, asked if I would be the lead person to go to Haiti. So we went on a 2-week mission to Haiti. And while I was there, we did a whole bunch of things. And there was a big group of us. And we sort of were negotiating the report. The people in the School of Public Health at Harvard were really slanting towards sanctions being a terrible thing. And we were sort of saying, you know, slow down. You know, this... So, for example, things like vaccinations, the whole vaccination campaigns in Haiti broke down, and all kinds of kids were dying of things like measles because the whole cold chain broke down, because basically these small rural clinics, which were set up by Aristide supporters, were all destroyed. People were being killed, and that beach that I showed you was actually a beach where I went and I talked to an American who had been beaten, and her health clinic closed down because she was handing out free medicine and vaccinations to people. So that's why I was there at Jacmel. So we were kind of negotiating, and unbeknownst to us, the professor basically went behind our backs and released the story to the New York Times, and basically came up with this figure that, you know, the sanctions were killing 1,000 kids a month. And we sort of swung into action, and there was a press conference at the United Nations, and 2 of us flew down and we gave interviews, and there was a retraction. But by this time, this kind of story really caused a lot of damage, really took a lot of the pressure off the military. It took about another 2 years before Cedras was pushed out of power. Whether really things changed, I'm not sure, but that's just one part of the story. Later that year, I went to Croatia. I speak the language, and so I was a fixer for another project for Physicians for Human Rights. And this is Clyde Snow. I've got his picture here. He really is the one who invented the concept of using forensic pathology in human rights investigations at the international level. And he started that in Argentina with a bunch of students. And he recently died, and he had his obituary in The Economist and numerous other newspapers and periodicals around the world. He's a fascinating character. So here, this is a place in Croatia called Ovčara, where they dug up some bodies of Croatians who had been cleaned out of a place called Vukovar. Okay, fine. So we had permission to go in, and it was about a 6-week mission. So I had just an incredible experience with Clyde and the rest of the team from PHR. We actually weren't allowed to go to the Croatian area. The Serbian authorities who controlled the area at that time said, no, you should go to this place. We're not going to let you dig up these dead Croatians, but you can dig up these dead Serbians. And sure enough, where we were, PHR is completely, they don't really care about nationality, et cetera. We're very interested in promoting human rights around the world. And sure enough, there were a bunch of dead people, you know, lawyers, housewives, people with briefcases, you know, their hands bound, killed, et cetera. So bear with me. Where's this guy going with all of this? So that was Croatia. And then I returned to my residency in Toronto, and so, you know, you're a bit sort of post-stress, and you're wondering about all these things, and you're being put back into residency. And I was exposed to these sorts of things. And during this time, too, I did another year at ISIS, sort of like a little mini fellowship. And this is a paper by a guy named McArdle and Hole, and there was others by a guy named Hermanek from Germany. And what this basically shows is he lined up a bunch of surgeons over time, and he showed local recurrence rates varied among these surgeons from 0% to 21%, okay? And that has been repeated since. So if you look at any outcome, there's always great variability. So where does that, how does that all connect? So as I think about all of these things in Haiti and places like Croatia, and even what happens in a system like the UK or Canada, you know, it makes no sense to me that there should be those disparities. So you know, why should anyone have to suffer like people in Haiti suffer? And why should anyone have a local recurrence rate, be exposed to a local recurrence rate of 20, 30%, versus if they go to another surgeon, it's 0 or 5%. And so really that's kind of what drives me. And if you're going to synthesize it into 3 words, it's systems, quality, and equity in ascending order of importance. So any system is set up and it produces the results it produces. And we presumably are all interested in quality, but fundamentally I think it all comes down to equity or equality, okay? And if you truly are going to think about making a change in a system to lead to improved quality, ultimately I think it all comes down to equity. And I still haven't fully fleshed out the, you'll have to buy my book. Okay, but let's just take you on a bit of that journey. So this is something that I did when I was at ISIS, a basic, very simple study. We looked at rates of vascular procedures. I was just told by David Naylor to go and do this project. And basically this is carotid endarterectomy over time. These are bypass procedures in the lower limb, and this is AAA repair. The details don't matter. What's fascinating to me is that you have such marked contrasts in a population of patients who have the same risk factors, atherosclerosis, hypertension, et cetera. And again, you can explain why all of these are happening, but really these dramatic changes in rates, it's all about a system, okay? So that's point number 1. I spent a lot of my research and health services research dealing with what I call healthcare zombies. This is kind of a take on Paul Krugman's economic zombies. These are kind of like truths or ideas that keep resurfacing. There's very little data to support them, but they keep resurfacing, such as if you go to a high volume center in Ontario for cancer surgery, you'll get better care. There's no data to support that. If you go to a teaching center, you'll get better care. There's no data to support that, but again, it just keeps popping up. We did a lot of work around lymph nodes. Again, there's a big push from Cancer Care Ontario to increase number of lymph nodes in colon cancer. We did some pretty definitive work to demonstrate that that was completely useless. We did a lot of work around wait times. We were one of the first papers to do wait times and sort of national exposure, et cetera. But we also showed that wait times really have no impact on things like survival, and yet there's such a fascination and obsession with wait times. Then we've done some work on financial incentives, especially in laparoscopic surgery, again, demonstrating that financial incentives have really little impact on the quality of care received by people. So this is sort of health services research where you're demonstrating gaps. And so, for example, this is our pancreas study. And again, just very, very briefly, we compared results in Ontario and Quebec. And what we showed is the blue lines are Ontario. I'm sorry, the yellow lines don't really show very well. Over time, marked regionalization of pancreas cancer surgery. So over this 8-year period, about 70% of procedures are being done in high volume centers, both in Ontario and Quebec. Now, right around here is when a big guideline and an audit and feedback exercise happened with surgeons across Ontario. And a lot of people just looking at this line took credit for the regionalization. So what we said is, well, look, you've got to look at what was going on before. And so at a system level, there were all these parameters and variables that were increasing regionalization. More importantly, in Ontario, you did see a big drop. You saw a big drop in mortality, but in Quebec, with this regionalization, you saw no drop with mortality. So again, in volume outcomes, people say, oh, results are slightly better, so we should regionalize. But we actually showed in one study that in pancreas cancer, that's just not necessarily the case. And I just met fortuitously Saud, who works with Christian Findlay in thoracics, and they're seeing the same thing. The marked regionalization of thoracic surgery in Ontario and across Canada really hasn't led to the improvements that people would surmise should occur according to volume outcome studies. So again, just a little, am I being correct, Saud? Is that true? There you go, see? There you go, see? Okay, so, so we dealt with a bunch of healthcare zombies and finding gaps in care. But then I said, okay, look, you know, enough's enough. Why don't we actually try to do something about closing gaps? And to me, that's what knowledge translation research is all about. It's actually trying to design better ways to bring new information quickly into practice, or to close persistent gaps in care. And shortly after I arrived, we did some pilot work, and then we're fortunate enough to get funding from CAHR for something called the Quality Initiative in Rectal Cancer Trial. And we randomized 16 hospitals across the province to a control arm or to an intervention arm. And this was the sort of knowledge translation strategy. And for any of you who are knowledge translation researchers, these are all pretty classic workshops with continuing medical education, opinion leaders, post-operative questionnaires or sort of checklists, audit and feedback, and the sort of central thing, which is operative demonstrations. We actually had the surgeons invite us into their operating room to demonstrate new ways of doing rectal cancer surgery. And there's a cadre of about 8 of us who flew around the province. Andy Smith and I did probably the great majority of the procedures, but we had all kinds of people who were participating. And, but it was a completely negative trial. There are absolutely no differences in this arm with this very intense resource-intense approach versus the control arm. And this is true of many knowledge translation trials. And again, knowledge translation interventions currently are sort of getting into that area where people just assume that they should work and that good things should happen. But when you actually look at the data, that's not necessarily the case, which informs our further work. Now, I always ask small groups, I won't ask you, you're too big an audience, what do you think the uptake of these operative demonstrations was? So actually having someone come into your operating room to sort of show you a new way, especially a relatively new surgeon to Ontario. And typically what people say, and this is what we anticipated as well, well, the surgeons would be very resistant. Like, who would want you to come into their operating room and all the nurses and the anesthetists and everybody know that you're there to sort of demonstrate a better way to do something, which kind of assumes that what you've been doing up to that date is not a good thing. So we really weren't sure what the uptake would be, but what we found was that surgeons were incredibly enthusiastic. So if any of you know about the diffusion of innovation concepts, here's a classic curve, and the idea is that uptake is very slow of a new technique, a new technology, and then once you hit about 20%, it really takes off. Okay, and that's actually, you can actually measure that. But what we found was almost like the iPhone, the new iPhone. It was like 35% of surgeons on their very first opportunity to call us were calling us to come into their operating room. This is back like in the early 2000s. And the curve just took off so that by their third opportunity, over 70% of them had invited us in to say, hey, show me this new way of doing rectal cancer surgery. So I find this very encouraging. And I really do think it speaks something about the professionalism of most people in the healthcare industry. Most people want to do the right thing, and most people are enthusiastic to improve and to improve the system. But how do we kind of capture that? So this is all part of the QIRC trial. It was a negative trial. But what we